All right. Hi, Dr. Brooks. Thank you so much for joining us today. I'm Samira Daswani, the host of the Patient from Hell podcast. We just renamed it fairly recently. It took me a bit of time to embrace that identity, but we're there. We are Manta Cares. We're a community of caregivers and survivors of cancer. We create tools and resources for anyone around the world experiencing cancer. We today have thousands of people on our newsletter, and of course, we have this podcast. So it's incredibly my pleasure to have you here today because you are our first medical oncologist on this podcast.
Yes, well, it's an honor to be here. Thank you for inviting me.
Of course. Before we get started, I would love to hear more about how you came to be a medical oncologist.
Sure. So the story has to start with the fact that my father was an oncologist, a medical oncologist. So I'm not the first oncologist in my family. And so obviously I had that example growing up. And when I was deciding to go to medical school, I didn't go with the intention of sort of following the exact career path, and specialty of my father. But when I got into medical school and started seeing patients in the clinical rotations, I realized that I really did enjoy working with cancer patients. And it was something about the relationships, the physician and patient relationships, and it's also an interesting field, a scientifically interesting field. So it was those two things, but I think mostly it was the fact that I just enjoyed working with cancer patients. It seemed like a high stakes relationship, and it seemed like if I was going to go into medicine, I wanted to be involved in those kinds of high stakes relationships to help patients with cancer.
Can I ask you a follow-up there? What about the cancer patient is different than other patients?
Sure. So I think some patients when you're a medical student, which is when you're making these decisions, some of the patients, it feels very episodic. It feels like you're meeting someone and you'll never see them again. And some people like that. They like not necessarily having a longitudinal relationship with a patient. They like, I'm going to see the patient and the patient's, I'm going to provide help, and then that'll be the end of my relationship with the patient. I'll see each patient in sequence and have a one-time relationship with those patients. Whereas I knew that I wanted to do something more longitudinal. I wanted to have those longitudinal relationships with patients. And then, obviously primary care has a very longitudinal relationship with patients. But in primary care, I think often it doesn't feel as much of a high stakes situation. And there's nothing wrong with that. It's just, I was attracted to those more high stakes situations, I suppose.
I see. So it was all about the patient relationship. That's incredible. I love hearing that. And how did you end up in GI?
So that was happenstance. I did my fellowship I did my residency in internal medicine at University of Colorado School of Medicine. And then I started a fellowship in medical oncology at Dana-Farber Cancer Center. And when I got to Dana-Farber, my mentors, my research mentors, were in GI oncology, and Dr. Deb Schrag, who's now at Sloan Kettering, was my primary research mentor. She was a GI oncologist, and I realized that as I was seeing patients in GI oncology, that it was a great specialty for me. I got to see men and women. So if you're a breast oncologist, you see all women, and there's nothing wrong with that. But I wanted to see a mix of men and women, and I wanted to see variety. And my father is a general oncologist, so he sees patients with leukemia and breast cancer and lung cancer and prostate cancer. So I'm a GI medical oncologist. I'm not totally, I see patients with colon cancer and breast cancer and liver cancer. So I see a range of conditions, but not quite as wide as a general medical oncologist does. So I went into it because of, that's just how it happened in my training. But I like the variety. I like having a mix of different kinds of patients.
So the one thing that I think would be helpful for our listenership to understand is it's something that you mentioned earlier. There's the patient relationship, and then there's the academic research side of it, and the scientific underpinning, the constant change in cancer care, the cancer research, and how it sort of comes back to influence patient care. And I'm wondering if you wouldn't mind talking about that from your lens, because you've done fellowships and I know you do research on the side as well. So how does that play out in your life?
Yes. So, oncology is a field that is changing as fast as any other field in medicine. Um, and, oncology is a relatively young field compared to other medical specialties. Before the 1960s, there were really very few, if any, successful cancer therapies. In the 50s, 60s, 70s, there started to be more effective cancer treatments. Oncology became a common specialty over that time, so over that time, treatments were evolving, and the way that they evolved is through research, patient-oriented research. So there was a lot of basic science going on. I'm not a basic scientist. I did some basic science in my university, and it wasn't my strength. But I learned that I think I'm actually pretty good at sort of more epidemiologic thinking, and patient, and thinking about how patients interact with their doctors, and how they're affected by the treatments. And so, yes, my practice is affected by research, because one day a drug or a treatment approach will be in development, and sometimes we get a chance to participate in those research studies by enrolling patients in those studies. And then the next day, those drugs, we learn about the results of those studies. Some of them are successful, some of them are not successful. But we're always, I'm always excited, and I think most of my colleagues are excited when we learn, okay, here's a better way. Here's something that we can be doing better. Or here's something that we've been doing all along that is not actually, that we shouldn't be doing any longer. So, learning, being in a field that's evolving, that's, for me, is also fun. It's especially fun when it means that we can do better in taking care of patients.
So, Dr. Brooks, one of the things that we've had now, I think a couple of individuals on this podcast come and talk to us about is how individuals, and I mean individuals, caregivers, and patients can stay abreast with the changes. And one of the things that I know that a number of individuals struggle with is they don't come from scientific backgrounds. And what's been happening is patients, especially in the more sort of rarer cancer types, et cetera, they don't know how to necessarily navigate the scientific side of it. And I'm wondering if you've seen tools and resources that you might be able to point patients or caregivers to, saying that, hey, this is how I keep up to date with all of the research coming out. This is what you may want to watch. Is there anything like that you might be able to share with us?
It's a great question. I think that some of the, I go on Twitter, and I see, and I run into patients on Twitter sometimes, and that, sometimes can be a pretty interesting space to ask questions and follow people who are. So if you're a patient who has a rare disease, there are specialists in your disease probably who are on Twitter and might be tweeting about your. I think most, Twitter is a public forum, so it's not a good place for asking highly, individual questions about, private medical information. But there are some interest, asking more general questions about, what is a good treatment for this condition, or looking at conversations about those questions, which I'm always interested, because there are always these issues that sort of fall between the lines. So as a physician, obviously I'm not relying on Twitter to teach me how to practice, but sometimes there are questions where you're trying to figure out, what are other people doing? There's no right answer to a question, but you're trying to learn how do I do this thing that's new to all of us, and we kind of learn from each other. So there's a network effect there. I've also seen that Twitter and other online spaces can be good spaces for patients to meet each other. And there are patient advocates who, and there are organizations where patients sort of meet each other, and can really provide a lot of support to each other. So I've certainly seen that in there's something for colon cancer patients called Colon Town. And that's an online community that I know that a lot of colon cancer patients and rectal cancer patients have really found a lot of good information through Colon Town. And I don't have, any significant involvement myself in that, but what I've seen from that organization has been good. And I think there are other similar online communities, which, so as long as you're going to an online community where there are good is some leadership that that is steering that community in a direction that's towards things that are scientifically valid. Obviously, not everything that people do is based in science, but I think as an oncologist, we tend to focus on that science-based part of the treatment arena.
So there, I definitely would not have expected you to say Twitter. That was amazing. I think that was one of my honestly recent learnings at ASCO. I used to not be on Twitter. I just never had the desire to, I guess, but I think that was my biggest learning from ASCO. It sounds kind of wild because ASCO does a lot of learnings, but my biggest learning from ASCO was Twitter is where a lot of the conversations happen. And I am so glad that you just mentioned that, because I don't know if that's obvious to the patient. I think there are some patients on there, but I'm surprised.
Yeah, I think it's harder. It may be harder for people to sort of figure out where to start and figure out how to get into those conversations or find those conversations. So I'm not sure if it's how easy it is for patients to use it that way. But it is interesting because I certainly do run into patients there. And I certainly have patients who, not my own patients, but patients who follow me because they're interested in something I've said.
Wow, that's incredible. Okay, all right, that's going to be one of our key takeaways from today, I think. Speaking of ASCO, I actually wanted to give, if you're okay with it, a small story about how we met.
Sure.
And it was at ASCO. So ASCO, for the benefit of our listeners, is one of the largest organizations in oncology and largest influences in oncology. It brings together the global community of scientists, medical oncologists, patient advocates, life science companies, pharma companies, etc., under the same sort of umbrella. And this year, I bumped into Dr. Brooks at the patient advocacy reception. And we ended up having, I think it was for an hour of a conversation and a dialogue. And it was all about, I think, tumor boards. Do I remember that right?
Yes, that was one of the main things that we talked about. I do remember that.
And I was wondering, so I was reflecting on that conversation, and I feel as though I walked away with such a different lens on tumor boards, especially from the lens of a medical oncologist, which I don't think I fully appreciated prior to that conversation. And I was wondering if you'd be open to telling our listeners about what is a tumor board, why are they important, how do they unfold, and just diving into that one.
Sure. So tumor board, which has different names, but it's something that happened, that most interdisciplinary cancer programs have. So I practice at the Dartmouth Cancer Center in Lebanon, New Hampshire, which is a university-based hospital system, but it's a relatively rural university-based health system in the United States. And we have a tumor board and we have many tumor boards in our cancer center because we are a fairly large cancer center for our area, and each tumor board is focused on a specific disease type. So I attend the tumor board that I attend is focused on GI oncology, and what it is it's a meeting that happens once a week. Other tumor boards might happen once a month or once every couple of weeks. We have high enough volume of cases that we meet every week. And the attendees of that meeting are medical oncologists. So there's 4 medical oncologists who attend this tumor board. There's 3 colorectal surgeons, 2 radiation oncologists. There's at least 1 diagnostic radiologist, and usually 1 or 2 interventional radiologists. And then there's the pathologists. And often there's also trainees, fellows, or other people who are doing a residency or fellowship. And we sit, in the old days, we all sat together in a room, and there was a projection screen, and we discuss a dozen cases over the course of an hour or an hour and 15 minutes. And then we project images, the CT images, and we project the pathology up on the screen. These days, a lot of it now happens on virtual meeting spaces. Although we still do go in person. There's actually, I think, real value to going to it in person, where you can actually see these people who you share patients with, but who you might not actually see them personally, because we practice in different locations in the hospital. So it's the one time a week when we really convene, we get together, nothing I'm doing in the care of a patient is happening in a vacuum, or very rarely is that the case. Usually patients, there's questions about surgical treatments, there's questions about the radiology or the pathology, there's questions about radiation therapy or other interventional treatments. And so so the cases that we bring to Tumor Board are cases where we have questions. And it might be a patient with a new diagnosis of cancer, or it might be a patient who I've been taking care of for years, but the situation has changed. There's a new question that I want to address with the Tumor Board. I could just send the patient to another specialist, but that specialist, that doesn't have the same context as 3 or 4 specialists sitting in a room talking about a shared patient or a potentially shared patient. So it's part of what we talked about, Samira, was how this is really valuable time. This 1 hour, 1 hour and 15 minutes a week. You have maybe 15 doctors in a room, or in a virtual room, and that's hard to accomplish. It's hard to get 15 people in a room, and so the time, if obviously we don't bill. The patients aren't. There's no revenue that is being generated during that time, because of course medicine's both is a business, and that's time that's not actually spent seeing patients or doing things that actually generate any revenue for the hospital. But it's critical to planning excellent care plans for patients.
So I think there are so many sort of threads in there that I'm hoping we can sort of start to unpack a little bit. I think for the first one, though, I think it's about the patient care, right? So it's 12 cases, hour and 15, so roughly 3 to 4 minutes per case. My first question there is it really based on whether there's a question that needs to be answered, or is it also an update? So the reason I asked that is we had Patrick Delaney, the exec director of the NCCN Foundation, and we spent the majority of that podcast talking about guidelines and the fact that NCCN has these guidelines of care, and they are largely used globally. So I believe they have 1.3 million oncologists across the world looking at NCCN guidelines and practicing according to the guidelines. And very often patients don't even know what the guidelines are. So that episode was all about guidelines. So you had the guidelines upon which a lot of oncology practice is being done. Then we sort of have this tumor board. So how do those two things work in conjunction with each other?
Sure. So the NCCN guidelines are, it is a very influential. Those are very influential documents. Basically, they're basically documents that document what these panels think is high quality care. They're not proscriptive. They don't give you only one and only one approach to doing things. And then there's lots of things that fall between. There's lots of areas that are highly subjective in patient care. It's also true, I mean, that the NCCN guidelines are sort of, they're written with they're written by a US organization. And so they refer to drugs that are approved in the United States, and they refer to treatments that are, sometimes available in the United States, but might not be available elsewhere. So they definitely have a sort of United States slant to them. But I think they're evidence-based, and these days, so much of the research is global. In terms of how does Tumor Board almost addresses issues where the guidelines aren't detailed enough, or where more subjective determination is required. Because if when we're talking about, I can follow the guidelines, I don't necessarily need other people's help to follow the guidelines. And 95% of the time, the things, or 99% of the time, most of the things that I do are consistent with the NCCN guidelines. Every once in a while, there's a unique situation or where the guidelines may not, that's, I think a good physician can identify when do the guidelines apply and when maybe do they not apply, and when should I do something that's a little bit different. 95 to 99% of the time, you should probably be following the guidelines. But in the tumor board, we're talking about sometimes the guidelines say consider liver-directed therapy. So a patient who has colon cancer, they have 3 liver metastases, and it may be feasible to offer that patient a treatment that actually tries to address those 3 liver metastases. I can give them chemotherapy. An interventional radiologist can do an ablation of those liver metastases. A surgeon can remove the primary colon tumor. And then maybe the patient also has heart failure or some other condition that makes this, complicated. So we have to get in a room. The guidelines talk about generic situations. Now we're getting into a room and we're talking about a specific situation. And maybe one of the tumors is close to the inferior vena cava, and that's going to complicate decision making about, whether or not surgery or ablation or other treatments are feasible. So really the guidelines are great, and I try to follow them whenever, the great majority of the time. And then when we're talking about implementing a specific plan in a specific patient, then there's all these things that come up that are not addressed in the guidelines, and so we're doing individualized decision making.
So I love the case study you just brought up, because I feel as though that really makes it concrete in terms of how that can play out and where the guidelines sort of almost end and where the sort of personalization can begin. So in the case that you just spoke about, it sounds like you could have multiple ways of addressing those liver mets. And now you've taken that to tumor board, but you have about 4 minutes. 4 or 5 minutes, maybe if it's really complicated, I'm guessing a couple more minutes in there. But how does that play out? Because when you were describing the tumor board, there are a lot of people in the room that are there. So is it a presentation? Is it a dialogue? Like, can you give us a little bit more?
Sure. So in that example, I usually if I'm the one who brings the case to the tumor board, I'll present the patient. I'll say this is a 75-year-old man with metastatic colon cancer, and he's in generally good health, or he has some other condition. And then let's look at the question I have is about whether treatment of these liver metastases, and can we review the imaging, and then the radiologist will project usually a CT scan. So I've just spent, 20 or 30 seconds introducing the case. Then we spend a minute or 2 minutes, or it depends on how complicated the imaging is, reviewing the images. So there's some prep that actually happens in advance. The radiologist is usually reviewed, has done some preliminary review. So he or she knows, where to go in the imaging. And that's, we can all, without tumor imaging, is one of the great things that comes with the tumor board, is that I can pull up, in my health system, I can pull up anybody's scan at any time, but I don't have a radiologist next to me. I can read their report, but the report, a picture is worth 1,000 words, and the report doesn't describe everything. And then sometimes I know things that the radiologist doesn't know. So when we're in the same place at the same time, we can figure stuff out that that the radiologist doesn't know when they write their report. So then we're reviewing the images together, and then then maybe the interventional radiologist says, yeah, I could ablate those tumors, or no, that one, there's something that you wouldn't know, but that one's not going to be amenable to an ablation. So so the question is really about either radiation or surgery, and then the radiation oncologist is there and says, I think we could do radiation, but but there are other, there might be other considerations. And so having being able to do this kind of collaborative discussion in real time, it's one of those things where if you tried to do this over email or me making 5 different individual phone calls, it's just not going to happen, because there just isn't time. And, it's bringing the right people together at the same time enables rapid assessment and decision making. But it is rapid, and that's something that we talked about. When we met, was that these are pretty rapid fire, and there's not a lot of, I think one of the things we talked about is, well, where do the patient's preferences come into this?
Yeah,
Why
exactly.
isn't the patient there? And you're not the first person to bring that up. And there's been I've seen some, I think some perspective pieces about, we need to bring the patients into these tumor boards. And I think I told you, I'm not sure how that would work. I'm not sure how that would fly, because of, there's no way we could do the number of cases that we do. And so it would be a different thing. And so could we still accomplish, how would we accomplish all these different objectives? And I don't know.
I'm so glad you went there, because that's exactly where I was going to go next, which is, I think in my case, I knew what a tumor board was. I knew my case was being taken to tumor board after surgery, because I had achieved pathological complete response post chemo and surgery, and was at that decision point where they wanted me to start on an ovarian suppressor, which is standard of care. It's what the guidelines recommend, first line treatment. It's ovarian suppressor plus an aromatase inhibitor. And I refused to do it because I had really, really bad side effects. And they wanted me to be on it for at least 5 to 10 years. And I am looking at that and thinking of my quality of life and could not resolve it. I just could not resolve it. And to think about having such bad joint pain that you can't sit up and stand when you're 31 years old is, for me, inconceivable. So I pushed back, and my oncologist, and we're really good friends, my oncologist was like, I'm going to take this to tumor board. But I hit a point where I was like, look, I want to be there to present my case. It's my case. I'm the one pushing back. I'm the one asking for not following guidelines. I didn't want any tamoxifen. I was like, I don't want tamoxifen. I don't want ovarian suppression. I'd rather do this other alternative thing. Not alternative in the sense of alternative medicine, in the realm of Western medicine, wanted a different kind of line of treatment. And it really upset me that I wasn't allowed to go to tumor board, because I felt like I understood my case. I had looked at the science research. I had looked at all the data. I sort of had a sense of where the data sort of fell short, because early stage breast cancer is very common, sadly, but early stage breast cancer in young women is still not that common. And therefore the data has limitations on it. If you look at these studies where they present the outcomes, there's limitations on it. And therefore, I think to your previous point, your guidelines are fairly generalized, and I don't think they always apply to all cases. So I really want to go to tumor board, and I was not happy when I was not allowed.
So what you are asking for, to me, one, is perfectly reasonable, and makes, not only, I mean, who am I to say that something is or isn't reasonable, but to me, that makes total sense. Two, it's not, in my view, it's not what tumor board is for. I mean, in my view, tumor board is for addressing what are the feasible treatment options. And what you're talking about sounds to me more like, how do we individualize a treatment for a patient? And that, so if I can make any recommendation to a patient, and that patient can then refuse, they can decline. Maybe decline is a nicer word. And I'm acting as an agent of the patient. I'm trying to give them what I think is good advice that will best serve what I understand to be their objectives. And most people, the objective is, I don't want my cancer. If their cancer is in remission, the objective is to prevent it from coming back. If the cancer is not in remission, which many of my patients have advanced cancer, so they have active cancer, then their objective usually is to live as long as possible with an acceptable quality of life. And I don't get to define what an acceptable quality of life is. And in your case, maybe there are trade-offs in terms of, this treatment is the best treatment to prevent a recurrence, but it comes with this side effect. There's obviously trade-offs there. Not everybody's going to accept one person's trade-off. Their acceptable trade-off is not the same as another person. So in my view, that's part of my job as somebody's agent, is to help them figure out, okay, what are if you don't, if the sort of standard treatment, if you have a reason that's not okay for you, then we got to come figure out what are the other options. So you could go to Tumor Board to say the patient declines this treatment. Help me figure out the other options, because that makes more sense. It's not, I've told the patient to, this is not how I would approach it. I've recommended X, and the Tumor Board is going to side with me or side with the patient. That's not how I would see the scenario.
I am super glad you sort of put more layers in there, because I think that was also one of the ahas I had from our conversation at ASCO, which is the aha of at what point does Tumor Board really step in? What point should they step in? And I think the other one was institution by institution variation. Because I would imagine that Tumor Board at where you practice and Tumor Board where I was getting care may not be playing out the same way. And I'd imagine that the dynamics in the room are different as well, in terms of who's in the room, how are they in the room, who's running the meeting. It reminds me of, like, I work in life sciences, my day job's in life sciences. And even in life sciences, depending on what the topic is at hand and what is playing out in the room when you have 15, 16 people, sometimes it's just the individuals in the room that drive the dynamic and kind of how that discussion unfolds.
Well, I think that, the Tumor Board is a really interesting sociological phenomenon, is what you're pointing out. And I think it's true. I think, like, the way that a cancer center operates, the culture of a hospital or of a group of doctors, we like to think that, okay, we have a team. Our team has many layers. I have a smaller team of medical oncologists. We have a wider team that includes surgeons and radiation oncologists and radiologists, and I like to think that we have a good team, and I want to be part of, I don't want to be part of a team that I don't think is great. I want to be part of a team that I think is great. I don't think that cancer care is an individual. It's not, you can't do it as an individual. You can only do it in teams, or it's very challenging to do it as an individual. So, and I think that it's true that those meetings really set a culture. If you can establish a culture that is good or a culture that is bad. We talk about patient preferences in our Tumor Board all the time. And if I try to say, this patient wants, this patient has told me that she is trying to avoid chemotherapy, or this patient has told me that that avoiding toxicity is very important to her, because she knows that she has a disease a cancer that's not going to be cured. She knows that she's eventually going to die from this cancer, and she would rather avoid toxicity and live a little shorter than have to deal with high levels of toxicity. So it's my job to learn those preferences and bring them to the Tumor Board when we're sort of figuring out the options.
So there are sort of two threads I was hoping that we can keep pulling on. I think one of them, and I may give a bit of context here for our listeners. So episode 4, we spend about 25 minutes talking about how, from a patient's lens and a caregiver's lens, decision-making in oncology kind of feels like an infinite game. And it feels like this constant, and I don't think this is universally applicable across all cases, of course, but in cases where you have sort of different modalities of treatment, it goes on for a while. And by a while, I mean at least a couple of months, if not years. It feels like this constant, you're always at a decision point with new information. And it is high stakes. It goes back to how you opened our discussion today. It is high stakes. It's the trade-off between my life versus quality of life, my health span and my lifespan. It's this constant kind of struggle. And my lens is different than my caregiver's lens and my family's lens, and they may want different things than I want. So it feels like this infinite game. And we were going back and forth on, is it a chess game or is it an infinite game? Is it finite or is it infinite? Where does it stop and what's the outcome? Is there a win and a loss, or does it just keep going? And when you were talking about, as an oncologist, this notion of you have a team and you have this interdisciplinary team, and the objectives and the goals of that team are being influenced heavily by the patient preferences, it's something that we haven't previously unpacked on this podcast before. And I'm wondering if there's a way that we can think about the game analogy, because the game analogy actually came from my surgeon. it was at the point where we were making the call on, should we do a lumpectomy, a mastectomy? How do we think about it? What are the trade-offs? Are we doing breast conservation surgery? Are we doing a more radical approach? And that's when he was like, look, Samira, cancer is like playing chess. It's one of the reasons I keep doing what I do, because it allows me to have intellectual sort of stimulation, which I totally understand. I'm the same way, not an oncologist or a surgeon, but intellectual stimulation, I get it. But at the same time, it's that notion that you're playing this this game with cancer. And I personally think it's very compelling because it allowed me distance from my cancer treatment to think of it that way. But I was wondering how you think of that versus the team concept. Is it a team playing a game together? So is it more like a sport?
Well, so cancer, treating patients with cancer is my work, and so I have obviously many patients, and so I realize that my patients are more my patients have a greater investment in their life than I do. That's just inescapable, right? So now, obviously, I'm trying to help every one of my patients, but I also have to go home at the end of the day and be with my family, because that's important too. So yes, so oncology, part of what makes it fun, so I want my work to be fun. I think if my work is fun, then I do a better job for my patients. And the team, I do like working in teams. I think most people do. And so recognizing that we work in a team, and the more that we support each other, and the more that we share common goals. And I think there has been some research on teams, and the most effective teams share a common goal. They share a common understanding of what they're trying to accomplish. And I think what our team, especially we have teams that get bigger in concentric circles. Our smallest teams include the people that I work most closely with, which are nurse practitioners, advanced physician assistants, other GI medical oncologists. There's a team of 4 of us who are in GI medical oncology here. We have, other specialists in other types of cancers around us. So, I think we have the culture, coming back to that question of culture, is that patient preference is we are not imposing treatments onto people. We are trying to give people treatments that they want. And the way that we do that is by learning what they want. And also helping, even sometimes we don't understand what patients tell us that they want. We want to tell them, you say you want this, but I've seen other patients go through what you're going through. And let me give you some additional information about what you're going through and where this expressed preference might lead you, because we do have that benefit of seeing people go through illness. So I think I'm not sure if I answered the question you originally opened with, but.
No, I like that perspective a lot, because one of the other analogies that is early and I don't actually think we've shared it on this podcast yet is I've been thinking about the cancer experience a lot recently. And one of the sort of insights is cancer, as a patient and a caregiver, navigating cancer is analogous to going on a very, very long hike without a trail map. So you don't actually know when the next decision point is going to be. You don't know if you're going uphill or downhill. And to your point, you don't know if after walking uphill, you're so exhausted that you're going to make a different decision on which path you take.
Mm-hmm.
And it's really hard to foresee that.
I think that's absolutely, yeah, I think that, so I think that's absolutely true. And I think that, the idea that you can make a decision today that's going to specify every step along the way for the next year, for most of my patients, that's just not realistic. We're going to make decisions today to the best of our ability. I'm going to try to help you make decisions, and we're going to make a decision together about what kind of care plan we're going to use. But going forward, tomorrow, it could change tomorrow. It certainly could change in 2 or 3 months, and we have to recognize that.
I think that's been a more and more of a realization for me, because the more I hear patients talk about their experiences, the more I realize that the path they end up taking is determined by a sequence of decisions, but you just can't foresee it that far out. And grappling with that uncertainty up front is, I think, something that caregivers and patients really struggle with. I know I struggled with it too. I wanted a plan. I'm a planner. I want my plan. I don't want my plan to change, but I don't think that's the reality of what happens.
Yeah, and I think that that's tough for me, is understanding, okay, how much do what do I do in terms of, do I try to prepare my patients for every eventuality? I mean, that's impossible. And do I even want my patient to spend a lot of time thinking about, what if things go bad and we get to this point? Well, we can, on the one hand, we can deal with that if we get that. No, we don't want to go there, but if we go there, we'll have to deal with it when we get there. To what extent is it productive to spend a lot of time preparing for an outcome that none of us are hoping for? I mean, I'm not saying that it's not. It is, I think it's very important for me to be truthful with my patients and tell them, my goal is what are the goals of the treatment? The goal of the treatment is to help you live longer and feel better, but maybe not to cure you. And if I don't expect the patient to be cured of their cancer, I'll tell them that the treatment we're giving I don't expect that it's going to cure you. And other doctors might say it's not going to cure you, and I say I don't expect that it's going to cure you because there are sometimes things that are surprising happen. And then there's, I think there are many oncologists, and myself included, who believe that it's not our job to tell people what the future holds, because we don't know what the future holds. I think maybe you complain the crystal ball analogy. I don't have a crystal ball. Yeah, you did. You said, well, yeah, that, but so people ask us, well, what's going to happen? Like, I don't know. I don't know what's going to happen. I know what might happen. I know what is likely to happen. I don't know what will happen.
Yeah, and I think what you just said is, I think, one of the hardest parts of being a patient, because I think a lot of caregivers and patients don't have the tools to understand the data here, right? Because the data exists, right? For the most part, not always, but we do know what the probabilistic answers are, but they are probabilistic.
Right. And I think people in general, why do people buy lottery tickets? If we were all probabilistic thinkers, we wouldn't buy lottery tickets for the most part, but lots of people do buy lottery tickets. So human beings are not in their lives probabilistic. And yet the data that we have tell us probabilistically what's likely to happen, what's unlikely to happen. Correct. But they're not determined. We don't know deterministically what will happen.
That's exactly right. There's one more thread that I think we started on, but I never picked it up, which was, and this goes back to tumor boards and the fact that you can't charge and bill for it. Because I thought that was one of the phenomenal insights that I remember from our previous conversation, that I think I definitely did not realize it. And I think it's actually really important for us to unpack that one, because I think if the counterfactual there were true, I think how tumor boards might run would be very different.
Yes, I mean, so I guess the reason why I even brought that up is not I don't expect people to be that interested in what it is or isn't billable time, but it is obviously how we treat in any place of work. I have a fixed amount of time. My employer expects me to see a fixed amount of patients. If you asked me to design my work life, maybe I would say I'm going to see fewer patients. I'm going to spend more time on each patient. But if that were true, then there'd be patients who never get in the door and would never get treated. So there's always this tension between spending more time with the patient who's in front of you, or moving on to another patient who also needs help. And then the way that the hospital triages that is by the way that the way that the healthcare system triages these problems is they pay you to see patients, and they don't pay you to necessarily to spend time at tumor board. And so so I have all these incentives, just like anybody else. When I go to work, I have incentives, and I try to pay attention to those incentives because it makes my life a lot easier if I understand what I'm being paid to do and what I'm not being paid to do. I mean, obviously, taking care of fundamentally what I'm being paid to do is take care of patients with cancer. And so, and the tumor board is essential to doing that fundamental thing, even though I'm not, none of the people who are, the hospital's not generating any revenue while we're sitting there doing that. But we're doing the fundamental job of making plans to care for patients.
Thank you for covering that. I think the whole topic of how care is paid for is something that I am personally very committed to talking about on this podcast, because I don't think patients understand it. And I think there are big macro things that maybe patients don't need to really understand, but then there are very practical things that I do think patients need to understand, which is small things like prior authorization.
Yes.
If a patient and caregiver just ask for prior authorization, that alone, I think, would make a dent on their incredibly large financial bills. And this is all US context, right? Ex-US is very different, but I think there are things like that over the course of our work at MantaCare I really want to provide tools and resources around, because I don't think those exist today.
Yeah, the idea of financial toxicity has, there was, this term that was sort of has been created in the United States. And, the idea is that you can have toxicity from a chemotherapy, but you can also have toxicity from the high costs of being a patient. And yes, there's a lot of opacity in the system to, what kinds of things do patients have to pay for? And the truth is, your doctors don't know either.
Oh, I know.
It's very opaque to me. What is my patient going to have to pay for? And it differs from one patient in the United States. It differs from one patient to the next. So I may figure out what this patient is likely to have to pay for out of their own pocket, but it's not the same for the next patient. And so it's hard for me to then act as the patient's agent. I want to be the patient's agent, but I don't have any. I don't have clarity on. And the patient also doesn't have clarity, because you're not paying at the point of care. You're paying months later after everything's already happened.
I I'm so glad you just said what you did, because I can tell you in my case, I actually denied my first couple of rounds of imaging. So I found the mass end of December. It was December 17th or 18th. Got an ultrasound. They wanted to repeat the ultrasound. So they repeated the ultrasound. At the ultrasound, they were like, well, we need to do a biopsy right now. And it was December 20th. I knew my insurance was changing. I was at the end of the year. I asked the doc, and I was like, hey, how much will it cost me? And of course, there was no answer. And I was like, can't we call up someone and ask? And can you not get me a prior authorization for it? Because I'm literally sitting there, bare-chested, arm above my head. She has her biopsy up. And I'm like, wait, hold on. Have you gotten prior authorization? And the answer is, I don't know what that is. And I'm like, no, pause, time out. And I think the question I asked her, I was like, will I die in the next 10 days? And she goes, not likely. I was like, okay, we're not doing this right now. It's incredible though. It's the fact that you're sitting there, and had I not known that, I am certain I would have gotten a multi-$1,000 bill. And then when the clock reset on Jan 1, I would have gotten more bills, because now, of course, you have to repeat imaging, right? One imaging is not going to get it there. And I'm sure if it came back positive, and it's exactly what happened, right? That sort of cascaded into a whole bunch of other tests that had to happen. But it's the fact that you're sitting there and you need to think about these things. It's incredible to me. But
yeah, and many of us are I keep as my goal. The number one thing is just to figure, my number one goal is to address the problem. But yeah, and for many of my patients, that's the right thing. But there might be situations where the best thing to do is to say, let's stop. For instance, Medicare in the United States is the public, the national insurance program for people 65 and older. Medicare is great. Medicare pays, Medicare generally covers people's treatment very well. But they still have out-of-pocket costs even there. But so I know the rules of Medicare, because it's easier to figure out. So most of the time, I think the thing to do is to take care of the person. But you're right, there are circumstances where pressing pause is sometimes is the right thing to do, and sometimes it's not, and it's hard to figure that out.
I think it's really hard. And in that moment, I had no idea if I made the worst decision of my life or the best one. I had no idea. It was pure instinct, right? It was my first scan.
And
So
this is
it's,
why, these high deductible health plans that we have in the United States really don't work for a lot of people. If the deductible is so high that it's catastrophic for a person, or major, causes major problems, then yeah, then it's crazy that people are making decisions based on a deductible, which I think is basically what the situation
yeah,
we were in. Yeah.
that's exactly right. Because I hadn't had any care that year. So that's exactly right. And my clock was resetting, right? So
Whereas if you'd already had a bunch of care, then you'd say, please backload it all in. Yeah.
Correct. Exactly. So it's I think the patient journey and the cancer caregiver journey are really complicated, which is partly why we're on this mission. It's partly why I want us to be able to give tools and resources that are practical for patients and caregivers. Dr. Brooks, thank you so much for joining us today. I am so grateful that you took out the time to spend time talking about tumor boards, explaining what they are, sort of highlighting the dynamics there, talking about how you and your team of individuals working together in concentric circles is behind that patient and caregiver, and that the goals are really being set heavily by the patient preferences about how they want to live their life and make the trade-offs they need to make the trade-offs on. I love that we highlighted kind of the dynamics of the financial system in the US and how it influences care decisions, how grappling time for a clinician is really important, because I think patients honestly sometimes forget that you have a life too, and you yourself need to keep work-life balance in mind and keep yourself and your family happy. So I really appreciate you helping us sort of pull this apart and see the different perspectives here.
Yeah, no, thank you. And that it's always fun to I think it's helpful and fun to sort of realize that what the part of the perspective that I'm missing too. So it's a fun conversation.
Thank you.